I'm Sandy Hofferth in the Department of Family Science in the School of Public Health, and I direct the Maternal and Child Health program. And my colleague, Wendy, over here at the end, is a pediatrician and clinical researcher at the University of Maryland School of Medicine and is board certified in general pediatrics. And her interests are particularly in the prevention of child maltreatment. So I am just going to give you a little introductions to our speakers today, and then Wendy is going to help moderate and ask the questions and make sure we move through it. We have a set of questions to ask our speakers. So our first speaker, Rebecca Dineen, is Assistant Commissioner of the Maternal and Child Health, Baltimore City Health Department. She's co-lead of the Baltimore for Healthy Babies Initiative, along with the Family League of Baltimore. She has 17 years of experience in MCH program development, and of interest to me, she's worked in 14 countries on 3 continents in MCH, family planning, HIV/AIDS, malaria, and primary healthcare programs. She's a former Peace Corps volunteer with a Master of Science in Health Policy and Management from the Harvard School of Public Health. And so with that, maybe you should have Rebecca Dineen, or should I, and talk about Pamela Creekmur, who's our second presenter. She became health officer of Prince George's County in July 2012 after serving as acting since August 2011. She's a registered nurse and the first person not to be a doctor, is what the bio says, to be the county's health officer. She worked for Kaiser Permanente for the previous 20 years, managing a department of more than 550 people and multiple clinics across the county that provide a variety of services and a budget of $70 million. So between the two, we're going to have a very interesting session talking about the Baltimore area and Prince George's County. So first, I think Rebecca Dineen is going to start, and then Wendy is going to moderate.
Yeah, so I think I'll actually stay down here and ask the questions. So the first question is, what do you see as the most significant maternal and child health issues to address in your geographic area or jurisdiction, or in the state of Maryland as a whole, in the next year and in the next 5 years? And I'll turn it over to Rebecca to answer first. Okay. Sure. Yeah, whatever you prefer. Okay.
Counts on you. Okay.
Hello. It's great to see everybody here. And it's really an honor to be here. I thought this was at the College Park campus off of 95, a little further north. And so I was a little late, but I'm very, very excited to be here to talk a little bit about what priorities there are around maternal and child health in Baltimore right now, and what we're sort of thinking about for the next 5 years, and how this might be relevant in the state of Maryland. So I'm going to talk a lot about our vision around Be More for Healthy Babies, which is Baltimore's campaign to reduce infant mortality in the city. And our challenge in Baltimore City is making Baltimore a healthy place to have a healthy baby. And that's a very complex challenge because it deals a lot more with it's not just the health of a mother, it's not just the health of the infant, it's really the health of the whole society. And so we deal a lot with issues of social determinants when we think about infant mortality. So in 2009 in Baltimore, there were about 127 babies who had died, and 102 mothers had had stillbirths. And what was most important and something to think about, and what we think about a lot in Baltimore City, is how to reduce racial disparities, because there was a really terrible statistic that black babies were dying at a rate 5 times the rate of white babies. And we think about that as sort of 10 empty first grade classrooms, if you want to put it in that kind of perspective. And so why are babies dying in Baltimore? Well, they're dying in Baltimore for the same reasons they're dying anywhere else in the country or in the world. But with Baltimore, our leading causes are different from what they are nationally. Nationally, you start with congenital abnormalities. With Baltimore City, our babies are being born too small and too soon, so they're born preterm or low birth weight. And there are a number of babies, 20% of our babies back at this time were dying because they were not sleeping alone on their backs in a crib, so they were sleeping in unsafe sleeping environments. But probably what's most relevant, and probably to Prince George's County as well, is just the fact that there are many underlying reasons why babies are born too small or sleeping together with other people in their bed. And that's because we have a lot of unstable housing. That's probably the #1 issue in Baltimore City. There's a lot of neighborhood trauma, there's a lot of violence, there's a lot of stress. That doesn't make for a very conducive, relaxed pregnancy that's going to lead to a full-term birth. It also means that when you want to put your baby to bed at night and you think you're going to put it in a crib and you don't know what room you're going to be sleeping in, that makes it really challenging. And so we do, when we're thinking about this all together, we have mother's health problems before or while they're pregnant, not putting our babies to sleep safely, smoking while pregnant, and then second and a third-hand smoke exposure, alcohol and drugs, pregnant too soon after giving birth, so short birth spacing. We have a high teen birth rate and not getting prenatal care and high stress. So those are the factors that might be relevant across the world, but in Baltimore City, those are the most relevant and potentially modifiable factors that we have. But we also pay attention to, in Be More for Healthy Babies, to what are the root causes. So we're not only thinking about mobilizing ourselves around what's modifiable around birth outcomes, but what is really driving birth outcomes. And those things, as we talked about already, were housing, stress, racism, poverty, lack of education, violence, lack of resources. These are root causes, and so we have made some progress over the last 6 years that I'll talk about, but unless you're really addressing those root causes, those successes that we've had could very well change quickly with a change in leadership, change in strategies. What you're really looking about in a change in infant mortality and a sustained change is really looking at these root causes. So what are we doing about this specifically? Should I, Wendy, get into this right now, or?
So why don't you do that next, and we'll have the next question. And we'll do the first question with Pam.
Okay.
Is that okay?
Well,
That work?
okay, I'm going to be very confused going back and forth.
Okay, you know what, then go ahead.
And then I can,
So,
you might not be confused, but I don't care.
okay. So our second question was, what are the significant programming efforts underway or in planning to address such issues? So Rebecca's going to go ahead and do that, and then we'll have Pam go ahead and answer the first two questions.
So the vision in Baltimore City, and it's actually expanding now into a youth wellness vision, but for now it's wrapped up in that all of Baltimore's babies are born at a healthy weight, full term, and ready to thrive in healthy families. And we take a life course approach to birth outcomes, so we do believe that this has to do with the infant at age 0 all the way to when that infant, if a female becomes pregnant or if male conceives a child. So what is Be More for Healthy Babies? It launched in 2009. It's a collective action campaign with more than 100 agencies working together. It's chaired and supported and led through the mayor's office, the Baltimore City Health Department, the Family League of Baltimore, and then Care First, Blue Cross Blue Shield gave a lot of money, as have a lot of other foundations. And so how do we do our work? Well, first of all, we always take our research and our science and apply it, so the modifiable factors that I talked about before were all done through a literature review. In addition, we look at and listen to the community. Most important to us is what people have to say in the community about the work that's needed and about what they want to see happen in their lives, because you're not going to make a behavior change if you don't have buy-in from all your stakeholders. And so communities, after we've looked at our science and research, we spend a lot of time getting feedback formally and informally, both through qualitative research methods and also just through our regular discussions with communities. Then we also spend a lot of time analyzing the data that we have in Baltimore, of which we have a lot of different data sources. Many of them are in very different places, but there's one thing that we can say for sure is that when you look at infant mortality and maternal and child health, these aren't program data. We're looking at vital statistic data. That means we're looking at birth and death records and using those to tell you how well we're doing or how well we're not doing. And it's not something where you can say, oh, I've reached 1,000 providers and haven't I done well? It's really how many babies are dying in the city, and is that getting better or is it getting worse? And there's no way that we can change those statistics. They are what they are, and so that's a really important and transparent way of measuring the work that we do. We also take a lot of our data from child fatality review and fetal and infant mortality review. So that means we look at all of the deaths in the city, both the fetal deaths and the infant deaths, and review what happened, why these babies died, why these children died, what were the precipitating factors, what are the risk factors we should be paying attention to as we develop our strategies. And we match that against what communities are saying and what their feedback is. And you'll see a lot, I mean, there's a lot of resonance in all of these different things because communities may be talking a lot in Baltimore City, as you've seen the sticker on back of cars, I'm sure the rats are a big problem in Baltimore City. And so when you go into communities and you talk and you ask them what they really want to deal with, a lot of times you're going to be talking about rodents and other kinds of things that you think, what on earth does that have to do with maternal and child health? Well, actually it has a lot to do with maternal and child health because houses are filled with all kinds of exposures that are very poor for the lungs of a pregnant woman and are exposing a fetus. And so if you do have rodents and other insects and so on in houses, that fecal matter comes into the air and it becomes very toxic for our families. And so there's always ways when we're talking with our families and our members in the community to link back to what's important to them and link it back to what's important to us and make that marriage happen, because without that, with us sort of saying, well, it's really all about babies being born too small and it's very scientific and here are some very specific things we can do about it, that's never going to result in the sort of demand generation that we need for behavior change. The other thing we really do is understand and have focused a lot on trauma in our city. So making sure, for example, with maternal and child health, the staff at maternal and child health are all being trained in mindfulness, the supervisor specifically, in how you deal with managing stress on your job so that they can then work with their frontline staff in that same way so that when we're dealing with traumatized families, we're not re-traumatizing them or ignoring maybe some of the factors that are really affecting their behaviors. So I'm sure you all have heard of the Adverse Childhood Experiences Study. A lot of our work is derived from the findings of those studies, which show that many people with multiple adverse experiences are going to be much more likely to have health risk factors such as substance use, teen births, and other kinds of issues. So trauma, as being a really important part of our work in Baltimore City, is something we focus on a lot and something that we'll be seeing in our projection out into the future. We also started an equity institute within Be More for Healthy Babies that deals a lot with race and racism. And really trying to just start to talk about very, very honestly how do we as leaders in birth outcomes, as residents of our city, really think about issues of race and how that may be affecting the very people that we're trying to protect, our pregnant women and our infants. And racism obviously creates a lot of stress for people, that creates a lot of toxic responses in the pregnant women, which can lead to lower birth weight and smaller babies. And so we have to talk about these issues and start to bring them up in all of our conversations. And then we're always making sure that we monitor the work that we're doing. So that gives you sort of the big frame of how we do our work. We're obviously looking at the life course, which is the health of the mother and father before getting pregnant, social and medical support during pregnancy, and then education and services after a baby's born. The areas we focus on, we've talked about already, but are health care and primary health care, prenatal care and home visiting and nutrition, smoking, drugs, and alcohol being a big factor. Those are big factors in Baltimore. They may not be other places. Domestic violence and mental health that are all related to the idea of adverse childhood experiences and stress and the trauma that people experience. Safe sleep, breastfeeding, and family planning. So those are the areas in which we intervene in multiple different ways across the city. How we do that, sort of the strategy behind it, is not to take sort of safe sleep and say, well, as long as we are providing cribs to everybody in the city, that's going to solve our problem. What we've tried to do is look at things from the perspective of a policymaker, from the perspective of the service environment, so that whole supply side. But then we also think about our work in terms of what's happening in the community. Are they mobilized? Are they excited about this issue? Are they mad about this issue? Are they going to be ambitious to change their behavior and then the individual behavior change? So you really need to look at the supply side and the demand side in our work. So if you take just safe sleep as an example, and we would do this for every technical area we work on, some example of a policy might be the state-led policy that happened a couple of years ago under Dr. Josh Sharfstein, which was banning crib bumpers. So we were big advocates around banning crib bumpers. Not necessarily because crib bumpers were actually killing our babies in Baltimore, but because it gave us a point at which we could start to message out. Here we're banning crib bumpers in Maryland, which is a risk factor for infant death, but Baltimore City has a big problem. So policy and making sure we have an enabling policy environment and is a fair policy environment is really important for what we do. Policies also lead to guidelines, and so as long as they're guidelines, if we know that banning bumpers is important in Maryland, we need to make sure that all businesses are following the guidelines that have been situated by this law. And so we make sure that we standardize how things are done, whether it's across our service providers, across our social service providers, our medical service providers. Then at the health department, we really look at service delivery. Are we delivering services in a way that's culturally competent and getting across the things that we need to with our young people and our families in the city? So we look at screening and counseling. We have a single point of entry for all our moms and babies in the city to get into services that they need, and we train doctors, nurses, and social workers around the services that exist and the linkages that we need. So that's the side of the equation that we spend a lot of time on with Safe Sleep. We would, for example, make sure that every single service provider in Baltimore City, whether they live in Sandtown, Winchester, which is on the south side of the city, or up in Bel Air, Edison, all know that they're going to be counseling their families around alone back crib, no exceptions. All babies should sleep alone back on the cribs, no exceptions. So wherever you go, whatever service provider you have in Baltimore City, that's the message you'll get as a pregnant woman and as a new father. On the community side, we do a lot of citywide education campaigns and mobilization efforts. We're really interested in mobilizing people around the disparities, the health disparities, which are really astonishing in infant mortality, and getting people to sort of think about what can they do themselves in an empowered way to change their lives and really embrace the messages of a lone back crib. Because if you think of the mother, she has now cribs that have no bumpers. She goes to a service provider who says a lone back crib, and then she goes home with her baby, and her mother or her grandmother who put her baby on the stomach, and the baby slept a lot better, is saying to her, oh, you know what? Really, it's better. The baby will be more comfortable on their stomach. That's what the community mobilization is all about, is to target those grandmothers and our fathers and anybody else in the community who might be giving a mixed message to the women and men that we need in our city. And ultimately, we hope that that would lead to behavior change. But the point is that for any service area that we're dealing with, whether it's domestic violence or safe sleep, we need to be thinking about all of those levels and the implications within each. Our goals are that babies are born full-term and healthy weight. We're also looking at women and families advocating for themselves and feeling empowered to take action. So we think a lot about literacy and being healthy and strong. So how well are we doing? In 2009, when we started, there were 127 babies who died at a rate of 13.5 per 1,000 live births. In 2013, 91 babies had died at a rate of 10.3. So we have seen a continued reduction over a 5-year period, 6-year period now. A lot of that has been driven by our infant sleep-related deaths. So we had 27 in 2009. And in 2014, we ended the year with 14, and we're still being very, very aggressive in this campaign. Some of the materials that we have Safe Sleep, we do a lot of citywide mobilization, Safe Sleep, smoking, teen pregnancy, and literacy. So our Safe Sleep campaign is really what I've already talked about. We use great ambassadors who are women who've experienced infant deaths, who work with us and talk to other women and mobilize them around these issues. We talk to our dads and our other caregivers as well. We are spending a lot of time now on smoking cessation, particularly in pregnancy, but also the dangers of secondhand smoke and third-hand smoke exposure to our pregnant women and infants. Maryland's 1-800-QUIT-NOW line is an incredible resource now. It didn't, I think, used to be, but right now it is a phenomenal resource for people to really help stop the habit of smoking. And we do a lot of training with providers around how to get women into those services. These are other sorts of fun, sort of iconographic posters and materials that we put in bus stations and shelters all over the city to continue to use social marketing as a technique to help mobilize our families around our campaigns. I talked about the fact that there's a very high teen birth rate in the city, so one of our major priorities is teen pregnancy prevention. And we use a You Choose campaign. It was developed by young people called Know What You Want, You Choose. And this campaign has helped the city go from 2009 to currently a 30% reduction in teen births in the city. So we're very excited about that, but have a long way to go with teen births. And then we talk a lot about family literacy, which is all about making sure that our families are empowered to help our children talk, play, read, sing, and write, and do that starting from when you're pregnant through when the child starts school. We have lots of different posters and materials around this campaign as well. So we have a lot of other campaigns and work that we're doing, but I think that maybe sums up a lot of it, and I want to turn it over to Prince George's County so we can learn what they're doing as well.
Thank you. We'll turn it over to Pam to talk about what she sees as the most significant maternal and child health issues to address, and how Prince George's County is addressing them.
Okay, and I think I'm going to do exactly as she did with the pointer here. I'm safer with the button than I am this. So thank you, thank you, thank you. A lot of what you just heard about Baltimore City is for most of the counties in the state. The infant mortality rate was a priority made by I guess, the past governor. It was on everyone's agenda. And so I'm just going to go real quickly over the data for Prince George's County and then just try to think about some of the differences. But so I'm glad to be here. It's thrilled to be here. So when you think about maternal child health indicators in Prince George's County, one of the things that if you live here, you know that it's an odd kind of a mix of a county, culturally very diverse, almost as diverse as Montgomery County. Most people know that Montgomery County is very diverse. They don't know that Prince George's County is about equal to that. It's a majority-minority community, mixed urban, suburban, and rural, very educated population if you look at the numbers, relevant affluence, which makes our disparities and the health equities a really interesting conversation. There's a real visible, I'm in the middle of the budget discussions now, but there is a real issue with increasing the budget in Prince George's County to take care of some of the things that are very important to those of us in public health, and that's called TRIM. We won't get into that. Before this last season of ACA enrollment, we had a significantly large population of uninsured and underinsured. It was over 16%. I'm thrilled to say today it's like 9%. So we've been very successful with getting people on insurance, but we now need to teach them how to use that card. We were just having that conversation. Having the card and using the card in a preventative way is a whole different conversation. We do have a huge shortage of primary care physicians here in Prince George's County and FQHCs, unlike Baltimore. Prince George's County has one MUA, medically underserved area. Baltimore has 14. So when you look at the population and the land mass of Prince George's County, it's crazy. And a lot of that is because of the affluence of the overall county. With infant mortality, for us, we are thrilled about it. It has been project number one since I got here, and prior to that, even with the former health officer, Dr. Shell. But we've seen an awesome decline in our infant mortality rates here in Prince George's County since 2010. We really didn't believe the numbers for 13 when it got to just below 7. We didn't believe the numbers. I said, check. It just was crazy. But it was an all-community out campaign to try to make a difference in this area. You see I have it broken down by ethnic group, but the decreases are huge. We still are very high with low birth weight, and those are also problems. And so that's the area we're trying to tackle now, and there are a lot of indicators as to why that is still occurring. Our teen birth rate in Prince George's County, and we use the numbers from 16 to 19, are significant in our immigrant population. If you look at the numbers, there's a slight decrease, and these things can go up and down, and the measures we implement now takes years for us to see some of the difference, but there is a slight decrease, so you can look at that, and it is an issue for us. So when we talk about improving birth outcomes in Prince George's County, and she's adorable, wasn't she? Can you tell I want to be a grandma? I got a few years to go. I got a little ways to go. So one of the new things that we're talking about, and I'm thrilled that you covered everything, we have similar programs. Infants and toddlers, Infants at Risk, which is a program where we're in the hospital prior to, because we want to make sure these babies come healthy, and then they live much longer past that first year of life. But the new partnership that we have entered into with the Department of Health and Mental Hygiene and the National Institute of Children Health Quality. It's a program called COIN. You know we have acronyms for everything. That stands for, let me see if I get this right, Infant Mortality, Collaborative Improvement, and that's just too much, and Innovative Network. What they're doing is a multi-year grant that we are participating in. Baltimore City is involved in that as well, where we are educating our entire workforce to engage people in a different way with evidence-based information. We're engaging the public. It's a public-private stakeholders and group, but we're training people. When you touch a person, you're talking about smoking, you're talking about safe sleep, you're talking about it all. You're talking about domestic violence. You are, when you have them in a very non-threatening way, you are educating them at every touch. And so we're excited about that. Our staff needs the training. I don't think you can train enough. So what are the areas of focus for us? We improve sleep practices, as you heard earlier, smoking reduction during and after pregnancy. We spend a lot of time on pre and intraconception care. We want mom healthy before you even consider having that child, and that really makes a big difference. So we've got several programs with that, which is case management with women who are even thinking about getting pregnant, preventive preterm and early term births. The social determinants of health for our county are quite significant when you look at inside the Beltway. And so if you look only outside the Beltway, it's a beautiful picture. When you bring in the inside of the Beltway and you look at the lack of, you look at poverty, you look at available food, healthy food choices, you look at, on every indicator, it is a problem. And so our county and the health department is full in with the Transforming Neighborhoods initiatives that our county executive has introduced, where all great things and innovation have to happen inside that Beltway. So when I want to do resources in an area of the county that doesn't have any crazy outcomes, I'm looked at like I had two heads, because I should be doing that inside the Beltway where it really is going to impact and lift the entire county. This is about a community impact. So one of the things, and it's not, I don't have a slide, but I'm looking at my Ameza Hoda, who is here at the University of Maryland, soon to be a PhD completed student. Hoda has been a research assistant on one of our most active work groups, our infant mortality work group. We have a coalition that's community powered, we like to call it, and they have been doing some innovative things. They've been driving the health department to think in a different way. It's those young people, you got to keep them around. And one of the things that that group has done that made a big difference was we created a business card, front and back. It was a pregnant woman, an African-American woman, a Latino woman on the other side, and it just said, need help, pregnant, need help. And it was to link people early to care, get them, and we put them in Walmart, we put them beside pregnancy tests. So they were everywhere. Those cards are where there was a pregnancy test, there was a card. So there was a lot of innovative things at this group. It's an entire work group. We have 6 of them. It's about 250 community residents helping us reach out into the community. So I had to acknowledge her because she's sitting there looking so fresh and soon to graduate. One of the bigger impact things that we're doing, we have perinatal navigators, and most of the counties have them. We have them. We have community developers and nurses who really, their real job is to focus on those social determinants of health. So we talk about getting to the doctor, having those prenatal vitamins, but the bigger issue is around poverty. Am I eating the right foods? Am I even making that appointment to the doctor? Am I even clear that I want this child? So I'm, the behavioral and the emotional issues around that make people make bad choices. And so those are the kinds of things that they're trying to get at. The teen pregnancy, the increase in our immigrant population is of concerning. It's multifaceted, and so we are planning to focus on this in particular. There are a couple of nonprofits in the community that have recently been funded. We really want to partner with them to get at the root of that. And one of the biggest issues for most things that impact youth for us is the lack of parent engagement and information about abstinence and education. I am not one that's going to blame the parents. I think that it is our jobs to figure out how to reach you and get the information to you, and that's, I feel, as a public health person. And so it's a problem that we have to tackle. We're working that out. We have an abstinence program and a PrEP program, Principles of Responsibility program, that's been very effective in our health department with community churches and nonprofits and those religious organizations. We did STD well. We did all of the family planning well. What we didn't have was something for people who needed another alternative. And that Principles of Responsibility program was really great to avoid those unwanted pregnancies. And so similar to the you do choose. What are the issues that we're seeing? The availability of resources, just basic things, safe housing, affordable housing, food that's healthy, and choices that are affordable near me that I can walk to or that I can ride to. There are some communities inside the Beltway where you can go a full mile. And you'll have a food mart, but they don't sell food. So there are significant issues. there. Access to quality education and economics, jobs, livable wage. Our unemployment rate in the state is not that awful, but typically when you're looking at the types of jobs and the skill set, there's a mismatch. That's a problem. Access to quality health care. So I said it's a strange story in Prince George's County. We have affluence, but we have probably fewer physicians, family practitioners, OBGYNs, pediatricians than any other county surrounding us, including the District of Columbia. There are lots of things going on to make a difference there. That would take another whole conference, but just know that we're working on it. And it does involve the new regional hospital. It does involve a report that's coming out from a consultant for a primary care strategic plan to make a difference there. Health literacy is huge. We lean on the University of Maryland in such a way. Dr. Linda Aldori is just amazing. She is on many teams with us working on health literacy. And what we love about Linda is the things that we come up with, she meets with the community, and most of it goes into the trash because she is talking with the community and she understands health literacy better than most. And so she's educating our agency as well as the community. Health insurance, I said that already. We've got people with cards. They are not using them. They don't know how to use them. They don't know where to go use them. And it's even deeper than that. Understanding what this means, what a copay is, so that's the next frontier for us. And transportation. Surprisingly, we did something in the health enterprise zone, and we came up with a list of 10 things that would be the issues. Well, the number one issue that none of us thought about was transportation. We've got the bus, we've got Metro, but none of it connects, none of it makes sense. It's divvied up in crazy ways. And so that's a larger issue that health really needs to be able to make a difference to. So I'm pregnant, I need to get to my prenatal visit. How do I get there? Okay, and so what are the issues? There are more, plenty. Crime, I have to tell you, the double-digit reductions in crime in Prince George's County, you'll hear it on every news station. I can tell you it's real. I don't know if you're feeling it as a resident. I do. We love Chief McGaw and his whole team. It is making a difference. I need you to know that that's not just the police. They trained us well 2.5 years ago. The Health and Human Services organizations basically said, we want to prevent crime. We need you. We can lock them up. We can do the after-crime business. We need your thinking. Health, Department of Social Services, Department of Family Services. And so we had sessions together and we trained them and they trained us. So now they look at, when they're arresting a drug addict or someone like that, they're thinking recovery. I mean, it's like, it's really good. The narcotics detective is like, I'm looking at 25 people, I can lock up 2. What about the others? I was like, that's right, treatment. So it's really a wonderful thing. And all of that is the entire community. It's not just health. It's in all things. I'm going to shorten it because I think we're going over. The last thing is launch, and then many of you may be aware of Project Launch. It was a program that was in the Department of Family Services up until July of last year. They moved to the health department, so I'm getting versed in what this program is doing. But it was to make sure that all children were ready to go to school and able to learn and succeed. And that's the other piece of this, where we're talking about outcomes, maternal and child health. I have to tell you, our infants and toddlers program is a program specifically for children born with disabilities, and so that they can be identified early and then get into care and get plans to help them be the best that they can be. And I think I'll end on that note. Thank you so much.
So thank you, that was great. So given our MCH collaborative and who's sponsoring this session, our third question has to do with universities, and what we'd like to know is how universities can partner with health departments or the state to address some of these maternal and child health needs. So I'll ask Rebecca, go ahead.
So we partner a lot already with universities and schools of nursing and schools of medicine, but the ways that we really would benefit and do benefit are first and foremost just the contributions to formative research and our evaluation processes in any of the work that happens in the city. So really having excellent students and excellent faculty member helping us to come up with the ideas that will help drive whatever campaign or program we're doing, and then the ability to evaluate that. I think to that end, I have benefited tremendously from students who do literature reviews for us. It's just amazing how many meetings I sit in, and I do, and it's just racing from one place to another, and my team is racing, and everybody's racing, and really there's not enough people reading and thinking, and so I think what we could really benefit from students is excellent literature reviews, keeping us on top of the literature, sharing best practices, and most importantly, identifying what's working in other places in the country or other places in the world. What's happening in Africa, what's happening in Europe, how is it applicable to what we're doing here in Baltimore City or in Maryland in general. Those things what students have is time, and I know students don't think that, but that's having been a student and now, there is time to, and especially if that's your assignment, to really think about how to advise us, I think. And part of that is also having a responsive research agenda from universities. So there was something that Dr. Josh Sharfstein had started right before he left Baltimore City as the City Health Commissioner, and that was called Reverse Research Day. And it was not as well attended as it could have been, but what it was all of us in the health department and in the Department of Social Services coming up with topics and questions and putting posters together and challenging the researchers and the faculty member to take those questions and see how it might apply to their research agenda rather than being driven instead the other direction. And I think there's a lot to be said about that, because a lot of the questions that even come up in our community meetings are pretty deep questions that need to be addressed, but somehow get missed because I think we get maybe too tied up in the literature and the science and in what we're studying. Then finally, we love to be able to give back to students, and so we have prevention medicine residents, at least 4 who come through our bureau each year. And what we provide are projects that are mutually beneficial. So projects that will allow them to, they've had poster presentations, panel presentations, they've written papers through us, and also just learned about leadership in public health. And so we see ourselves as a training platform for nurses, physicians, social workers, midwives, as well as benefiting from all of the good work and brains and time they have.
I would just add that, is this on? You can hear me. I would just add, I don't know that we have a formal process for that back and forth, and it is absolutely necessary and needed for information and ideas. I think there needs to be more research around this issue around stress in pregnancy. There is a reason, we just don't know it. I know Dr. Liu, who is, I guess now is with HRSA, had done research around stress and the infant mortality in African American women, but I don't think there's enough research around for that topic, because we, more minority researchers would be another awesome thing to do. It is a topic, but there is a reason that we're not getting at that African American women are losing the babies at a larger rate than others. And the only factor right now that when you look at it, because African women who are in their own countries have an infant mortality rate close to where our Latino population is today, but 10 years after living in the United States, they are equal with African American women. And so there's a lot that can be help all health departments in the nation. If there's more research, I think some kind of way my health department could come up with a pathway where those bright minds are here. You've got an idea and there's some work you want to do, how we can make that a little easier, bringing that to us. Our health department, we consider ourselves the enabler and the communicator for the entire county. We love it. We haven't, up until maybe about a year and a half ago, had the capacity to make it a very good experience, a mutual experience for students and us as we were rebuilding and retooling and reorganizing. I think we're there now. We have enough people that would make it a mutually enjoyable experience on both ends. But there absolutely needs to be a tighter, more formal, more focused approach to collaborating and partnering on research.
And our final panel question before we open it up to the audience for questions is, how do you see the Affordable Care Act bearing on some of these healthcare issues?
Oh, well, I think I spoke a bit on it. You can tell I'm passionate about that. We did a great job in signing people up. We also knew that we had a large population that had not been tapped in years. Things had not been done, even some of the low-hanging fruit. We were forced to do it with the Affordable Care Act. My biggest concern as a public health person now and coming from the operations world is it is not intuitive how to use your health insurance. And that is my biggest concern. That is where we are focusing our approach from now going forward, partnering with the Health and Human Services agencies. But it's a wonderful thing. It was signed on my birthday in 2010, the day the Supreme Court ruling came. I think everyone at DHMH and myself was holding breath. But the day it came out in our favor, and I say our favor because I'm a passionate, I believe we didn't go far enough if you really want to know. So, but I think that it's a wonderful thing. I don't think we're going to go back. I do think we have to help our residents understand how to use it and that it's a good thing to use it. And that is a cultural barrier that's going to take us some years to crack.
And maybe just to add to that, I think that for Baltimore, it's clearly helped a lot of people gain access to healthcare. And so what I think our concerns with are that the Affordable Care Act provides insurance, and that is one piece of a bigger public health equation. But it's not ensuring the use of high-quality services, or that the services are culturally competent, or that the services are always available in the community. So if you do go to PG County, because we have the Affordable Care Act, doesn't mean that they have more healthcare providers. And it doesn't mean that we are messaging to our families in the right way. And I think in some ways, and I sort of looked this up on I've been working a lot with AmChip, and just thinking about the distinguishing factors between primary care services and preventive services. Because primary care, what we are allowed to do with the Affordable Care Act is use primary care services, which is essentially very, very, very essential, and in Baltimore maybe not as, it's very fragmented and needs a lot of work, but the Affordable Care Act can allow people at least to access primary care services. But preventive services, you know, activities that are aimed at population health or reducing the incidence of health problems or disease prevalence in the communities, or thinking about our community as a population, you know, community-based preventive services are not reimbursed right now through any mechanism. And those services are what we really do need to have to really create a linkage between what our families are asking for and how we can provide those things. And then, you know, I feel like in maternal and child health, there's such an interrelatedness between the health status of our pregnant women and our youth, along with educational achievement and social development and sort of the influence of our family and communities. So if we're thinking just about one piece of the equation, there's just many, many other aspects, and what we don't want to see happening is our Title V, which is the funding that comes from the federal government to support maternal and child health. For anybody to think that, well, because ACA is here, that therefore means that we can't, that we shouldn't be supporting our public health efforts, because right now those efforts are essential for most of the work that we've been doing. And I will say that what's happened with, and I love the Affordable Care Act, so don't take anything that I'm saying as not that that's a point of progress. But what is happening with Medicaid in the state is they've become very particular about following rules in ways that things used to be rather more gray. So there was some allowance for you being more of a public health practitioner as you coordinated the care of Medicaid clients. But what Medicaid no longer will do, and you know, not that it did before, but maybe did behind the scenes, is there's no care for our undocumented population anymore. And that is, so there's a big growing population in all of our jurisdictions that's undocumented, and that's not supported through this act. So to your point, it's just not going far enough. And then the other thing is that Medicaid, in terms of saying, we only pay for what is about coordination of this patient. So when we used to be able to take our coordinated care funding from Medicaid and support our central triage system that brought pregnant women into, linking them into services of care, our funds are now getting cut by Medicaid, saying, oh, well, you have fewer Medicaid recipients in Baltimore City compared to, say, Montgomery County, which is growing in its Medicaid population. So therefore, we're going to cut Baltimore City's funding and, you know, pass it to other jurisdictions. PG County hasn't benefited yet, I pointed that out, but passing it on to other places. And so I think the point is that we just want to be, I think there's so much good that's happened, but I think it's really important for us as public health practitioners to absolutely advocate that these block grants and these other ways in which we support public health are maintained and are understood as offering something that's extremely valuable in our country.
Yeah, so we'd like to open it up to the audience to see if you have questions. We have about 5 minutes left.
Yes, please come to the mic, yes. Dr. Shanasa.
Hi there. Thank you very much for this very interesting talk. I have a question. Ms. Dineen, you mentioned the reversed research day, and Ms. Creekmur, you mentioned some research on stress and among minority women. But so it's a question for both of you in terms of any suggestions in that regard. So areas that you see that require more research. Maybe if we can start with you, please. Well, it's a question for both of
So I
you.
am not the expert on the research. When we searched so when I first got here, I asked the question, what are we doing as a state? I looked at the disparities because I was learning this public health field. I'm more operations for many years. But there was very little conversation, discussion, so I got a few of my folks to do some research. I sent some of my staff to see the work that Dr. Liu, his name kept coming up. And I'm like, there got to be other names who's doing research on this issue. But I can't say which areas. I think that this is the difference. I think, and it's my very small mind, but I do think that there is a linkage to that issue with stress. And whether we can fix it or not, I don't know. But there absolutely needs to be more information and more research around that. I'd love to have Prince George's County be a source of some of that. Because the numbers are, at one point when I got here, I think the infant mortality rate in African American women was around 13. So we've got the total rate down to below 7 now, but there's still a huge disparity, and I don't have the answers why. And more research around that would be wonderful. Collaboration with this university and the School of Medicine, NIH, we partner and we would help anyone who wanted to get money to do that kind of research, because I think there is something there. Thank you.
For research topics, I think to me, it really is taking this on as asking at your health department or whatever your local jurisdiction is to say, what are the major questions that you all have right now, whether you're running the lead program or you're running the Safe Sleep program. One question that just comes to mind for me is we have just a huge unable to locate population in our city. There are people that are just really hard to find. Now, we sort of know the reasons that they're hard to find, but where are the best practices around finding folks? How do we think about this as a state, that these are families that are really vulnerable, and how do we get them linked back into the system? There's just nothing really good out there that indicates that. And so we use a lot of our scrappy public health investigators to help us think through strategies, but there may be some science behind that we're missing. And another big area that I think is pretty interesting is just coalition measurement and measurement of success of networks, and how the more cohesive a network is, the more likely it is for referrals to happen in a systematic way. But how do you actually measure that? As if you're in charge of a coalition, how do you really see the changes in the coalition over time? And there's something called the Wilder survey that City Match, which is a maternal and child health organization, has that helps with that, but it doesn't really get to sort of questions of, if we're looking at collective impact, what are really the metrics we should be using? There's so many questions. I think my staff is probably best able to come up with research questions, but I just love the idea of having a research question that, somebody who is a health program administrator came up with and then wrote a poster about, and then we literally held it in a forum room at Hopkins, and researchers came and looked at the posters. But I don't think it was promoted all that much, and so I don't know that it actually went anywhere. So it's really a different paradigm and a shifting of a paradigm, and I would be really eager to think about how those sorts of things could happen.
Time for maybe one more. I guess the question I have is, you're talking about so many differences across, Prince George's County is such a large county. Baltimore City is intense, but has many different neighborhoods. So are you thinking in terms of different strategies for different parts of your communities? That's really what it sounds like. The same issue might be different for different parts of the county.
Absolutely, we have to. I said we are rural, suburban, and urban. When we worked with the state on our infant mortality numbers early on, and we were looking at the pockets of them, some of them didn't make sense. And so what the office at that time, it was called the Office of Primary Care, they had mapped out some of the information prior to us doing this. And there was a pocket of high infant deaths in the, I call it Collingswood, Bowie. So it was not a low-income area. It was they didn't have many OBGYN doctors in that area, but it's really affluent community. And what we, as we started to do the research and we started asking the question and pulling the thread, was what we found for our community is that it crosses all socioeconomic statuses. I am actually a poster child for infant death, educated healthcare professional working, 28 years old, and it happened to me. Not expected at all, no history of that. And so when you, the good story is I have a 24-year-old, 3 years after that, but also she was a 29-week preemie. So there is something to this issue. I had a high-powered job, educated nurse, knew what to do, did those things. And so that's what we were finding in that little area of Bowie. And so we have to have different strategies. Our communication, which our team is working on now, it's got to cut across everyone because you're at risk. If you are, particularly if you're an African-American female and you want to have children, there are things you need to know because you are at a higher risk than others. They've not finished crafting that message. Any volunteers who wants to help with the research on that, bring them on. And as she said, my expert in the health department is Diane Young, who is the associate director for our, we call it Family Health now, but it was called Maternal and Child Health. She eats and sleeps this. She probably should have been here today because she would have been way more informative on all of these programs. But we would love the opportunity to do some real work in this area. So that we have to do something different in different segments. So the answer to that question.
We did map out the city and by excess infant mortality by different community statistical area. But a lot of what we do is we try to have universal messaging. I mean, a lone back crib, no exceptions would be applicable no matter who you are. But then you may have a different strategy for reaching our harder to reach population or our Spanish speaking population. You might need different language materials, so we try to do universal messaging, but getting those messages to different areas requires very different strategies.
And funding for campaigns, which typically goes when there are tight economic times. Funding for that in education and conferences and training is the first to go. I fight to keep a little bit of that, but I do fight hard too. But yeah.
I'm just thinking about what you're saying. They're all very interesting research topics, and I think we need to think more about how to tie our MCH collaborative with the health departments and figure out how to translate your questions into actual research. So thank you.
Thank you, and thanks everybody.